Hello, everyone, and welcome to Live at 5. This is our special on-air program today about breast cancer as we kind of wrap up Breast Cancer Awareness Month here in October. I'm Sandra Mitchell. I'm going to be your moderator today as we talk to some experts about what's going on in breast cancer, both in diagnostics and technology and the advances that we are seeing. Many of you know me as a television anchor and reporter here in Los Angeles, but what you might not know is that I'm also a breast cancer survivor. 10 years ago, I was diagnosed and treated, and I'm happy to be looking at that part of my life in the rearview mirror. All right, we have some really special expert guests with us today, and we want to get right to those guests. First, we're going to introduce to you Dr. Ashini Master, and she is with UCLA Health. Dr. Master, welcome to you, and go ahead and tell us a little bit about yourself and your background.
Great, thank you for being here. I am a Southern California native and spent about 9 years on the East Coast during my training and came right back to the warm weather. And am now a breast oncologist at UCLA. I see patients in our breast center in Santa Monica, as well as a satellite center satellite site in Beverly Hills. I do run our high-risk breast cancer program. This is for unaffected women who have family history or genetic mutations. And I'm on the medical advisory board of a couple nonprofits locally as well.
Dr. Master, thank you for everything you're doing, really, and for your volunteer work as well. We're going to switch gears. We'll get back to Dr. Master in just a moment, but next we want to go to Dr. Gregory Vidal. We're going to go from Southern California all the way to Memphis, Tennessee. Dr. Vidal, thank you for joining us, and go ahead and tell us a little bit about yourself.
Thank you very much, and thank you guys for inviting me to this program. I am, as you may notice, a little accent. I'm from a small island in the Caribbean called Dominica. Came up here for undergrad, here as in the United States. And for myself, always interested in medicine, but oncology came through a roundabout way through some family experiences. I'm at the West Cancer Center in Memphis, Tennessee. I'm a breast medical oncologist. I spent about maybe 60% of my time doing sort of clinical work and about 40% of my time doing clinical research. I currently run the clinical research department and head the breast cancer program over there. It's really a passion of mine, and I hope to be able to convey some of this information to you, the listening public. And thank you again for inviting me.
Thank you for joining us. Fascinating background. Thank you. Love the accent too. All right, let's go to Aubrey Kelly. Aubrey is joining us from Rabble Health, which is new in the technology world. We're going to talk about that, but you also are on the board at Children's Hospital here in Los Angeles. Aubrey, a little bit more about yourself.
I am. Thank you. So, yep, Aubrey Kelly, founder and CEO of Rabble Health. A little bit of a personal background. So my son is an acute myeloid leukemia survivor, and appreciating the pace of innovation. So Dr. Vidal is doing phenomenal work on the research side, and the actual pace of adoption, there's a bit of a gap there. And so I felt that there was a wonderful opportunity to actually use technology to break down some of the systemic barriers that we see and really help patients who are newly diagnosed access resources, access services, and information to truly live through cancer better. I'm obviously biased towards pediatrics and blood cancers, and so our starting point is breast cancer. And so I've had the true privilege these last few years to really dig deep into understanding disparities in the breast cancer setting, how information and technology can actually be used to help address those. And I'll just do a little shout out. I'm a UCLA Anderson grad, and Rabble Health was actually part of the Anderson Accelerator. So excited to be here. Thank you.
Go Bruins, right? All right, Aubrey, thank you. All right, let's talk to Mark Pilon. My good friend Mark is he is the executive director of Susan G. Komen here in Los Angeles, joining us in his pink as always. Mark, a little bit more about you.
I own a lot of pink. My name is Mark Pilon. I'm the executive director of Los Angeles affiliate of Susan G. Komen. I've been with them almost 10 years. and came to it because I have a lot of the very important women in my life that have had breast cancer and that have died of breast cancer. And when the opportunity came up to serve in this capacity, I kind of jumped at it. It was exciting to me. One of 8 kids from many years ago. I went to UGA. I was in a pre-med program for nuclear medicine. I wanted to go into nuclear medicine. And so it's kind of like this full circle. I wanted to go into it because my godmother had died of breast cancer, and I wanted to cure the world of breast cancer and not have anybody else go through that again. But I wound up in the autumn of my career going back to being able to serve breast cancer patients every day, and it really is, it's fulfilling. It's extremely fulfilling. I'm a grandfather of 3 and a father of 3.
And I can attest that you do it all with so much enthusiasm, Mark. Thank you. All right, we're going to go ahead and get the questions portion of this started, and we're going to start with Dr. Master. And Dr. Master, I've been hearing so much buzz about new therapies for breast cancer patients. Can you tell us what you see emerging in the world of treatments and therapies?
So much, it's hard to know where to begin. There have been multiple drugs approved just in this year. I would say some of the more exciting things that have recently come to light for our patients with early stage breast cancer that's hormonally driven. We now have a new FDA approval for a drug named abemaciclib, and found that there was significant improvement. Hopefully long term. We're waiting on some longer term
I think that we're
follow-up.
losing your signal a little.
Can you hear me okay?
And we're going to go to Dr. Vidal, see if we can get a better signal from you, Dr. Vidal. Can you tell us a little bit more about treatments and the new therapies that we're seeing, and what's new in the world of breast cancer that you're sharing with your patients?
Thank you. And I will just continue the conversation that was started, and I hope you guys hear me okay. The good doctor was talking about new therapies, and she was mentioning a drug, specifically abemaciclib. That drug has been approved, at least the class of medication have been approved in the metastatic setting for at least, I think, the last 6 years, and essentially has revolutionized the way we treat estrogen positive metastatic breast cancers. Patients live longer, they respond for longer periods. And recently we just had, as in last week, we just had an approval for one of those drugs in the early setting, and which showed improvement in the risk of having this tumor come back. Other important and a little bit more dear to me is the triple negative space.
Mm-hmm.
The triple negative cancer, as some of you may know, is a little bit more common in women of color, and it is one of the types of breast cancers that has been lagging in terms of new development and new treatment. It's more likely to kill a patient. Patients are more likely to recur. But recently, we've had the approval of an immunotherapy, pembrolizumab, in combination with chemotherapy in the early setting, that has shown not only improvement in the tumor disappearing or completely being killed with chemotherapy when you take it, with the treatment when you take it before surgery, but it also seems to improve your chance of this tumor not coming back. We again still lacking long-term overall survival data, but those are sort of the new therapies that have been showing up in breast, and we're very excited. I do a lot of clinical trials. There are lots of other drugs being tested. Some of those that are probably will soon see as part of our arsenal are drugs called SERD. There are kind of like they're anti-estrogen therapy, but they degrade the receptor instead of inhibit the receptor. And those will likely show up in our arsenal soon, and we're also testing those. So there are lots of exciting new drugs to come through.
Yeah, I hear the excitement. I hear the positivity in your voice, and thank you for what you're doing and just encouraging patients there in Memphis. Most of the research that is happening now, of course, needs a lot of funding, and I know that Susan G. Komen is a big part of that funding. Mark, talk to us not only about the outreach that the organization does, but also how the dollars are used, all those fundraising dollars.
Well, all those fundraising dollars are really, there's some, and recently we've become more patient centric throughout the United States, but there's a lot of our money that goes directly towards research, and our focus, I think over 33% of our grants this year are specific to metastatic breast cancer. And so we're really trying to, because women only die, or not only die, the vast majority of women die from metastatic disease.
Mhm.
And so that's where our concentration is right now, is trying to end that and then kind of work backwards. We'll probably never be able to end breast cancer, but we want to get to the point where every woman has an opportunity, or every symptomatic man has an opportunity, that once they are diagnosed, that we can provide all the services. If they're diagnosed sooner, then obviously the cure rate is much higher. But we have put in over right at $1 billion. We are second only to the U.S. government for cancer research, for breast cancer research, in new modalities, in treatments and medications, in all kinds of things that help move the needle forward, so we can end this disease as a disease that kills 44,000 women a year in the United States. And we want to be able to change that.
Funding, fundraising, talking about it is so much a part of what is needed out there, but also what's needed is a support system. I remember just feeling overwhelmed and not really knowing where to turn. And I think that's one thing that Rabble Health is doing. Aubrey, can you tell us, this is an app that you can get on your phone. Tell us a little bit more about your intentions for Rabble Health.
Absolutely. So, and before I get into it, I just wanted to also highlight the good work that Susan G. Komen is doing, not only to create and really innovate on the therapy side, but I know of a particular city that is actually leveraging Susan G. Komen funds to help increase screening rates within areas with the biggest disparities. And so I just wanted to acknowledge that the research really transcends the entire patient journey. And the importance of that starting point at screening not only is accessing facilities to have appropriate screening, but once a person is diagnosed, it's truly a traumatic stressor. And there's a lot of information and a lot of key decisions that are made early on. And there's also a recognition that 80% of cancer patients are actually treated in the community setting. And so one of the solutions that we have is a platform, an iOS app, an Android app, and a web app called My Rabble. And the first step is actually not to inundate an individual with a ton of information, but to actually help her build out her team. So you can invite your spouse, your brother, your sister, your aunt. You don't have to invite your neighbor if you don't want to, but this the ability for a care team to actually access the same information allows not only that kind of social reinforcement for an individual patient, but it also allows us to reduce the noise. So with our platform, we have an opportunity to let the technology do the hard work. So as a person logs in, she's able to identify, I'm a HER2 positive, HR negative, stage 3 breast cancer patient. What are some considerations as I go through those steps of screening to treatment, or excuse me, screening to diagnosis to treatment and beyond? And how do I communicate some goals of care, do symptom tracking, and access advocacy organizations accordingly? So we're in early stages. We're actually building out our first patient beta group. And so we have an opportunity to really learn and identify how we can triage an experience that's really quite meaningful for patients along that entire care continuum.
It's really insightful. I remember when I was diagnosed, Aubrey, just frantically writing down notes on a notepad, and later couldn't make any sense of them or what they meant or where to turn. So it's really Really fascinating. Thank you. We have a lot of experts. We have a lot more questions for our experts later. We're going to invite you to input your questions as well. Right now, we're going to take a quick break as we hear from some of our sponsors.
Hi everyone, my name is Andrea Light and I am a 6-year cancer survivor. My biggest piece of advice to anybody going through this is to maintain a positive attitude. Try to stay focused on real life and the future. I was a single mom with 3 kids and a busy career and a busy life, and I didn't have time for this. Nobody does. So I chose to continue to focus on my life and all those things that mattered to me, and cancer treatment was just one more thing I had to deal with in my day. But I tried not to let it consume me, and I tried to, again, just focus on my real life and focus on the future, on what it's going to look like on the other side of this. So just know that the scars and stories that come out of it are just going to make you a bigger badass than you already are, and you're going to be okay. So I wish you well in your journey, and I wish you good health. Thank you.
At the UCLA Health Johnson Comprehensive Cancer Center, our doctors, researchers, and specialists are here for you. Our discoveries, developed for patients here and around the world. Our treatments, rigorously tested. Our journey, a collaboration, because we are part of this community. Here, we will continue to shape the future of cancer care. So the next chapter of life will be there for you. We brought Keytruda to patients to treat metastatic melanoma. This game-changing immunotherapy has raised skin cancer survival rates. And we developed Herceptin, a breast cancer treatment which has saved countless women's lives. Our confidence comes backed by science. The work in our labs is transformed into treatments that change our patients' lives. We validated for use the PSMA PET scan, a better way to locate prostate cancer so it can be treated. And we were among the first medical centers to implement Meridian LINAC, allowing radiation oncologists to track tumors in real time so they can be eliminated. We're building on the science that came before us and training a new generation of scientists who join us. So we can put tomorrow in your hands, because this is for you.
Welcome back to Live at 5 as we continue our special discussion today about breast cancer as we wrap up Breast Cancer Awareness Month. And our friends over at UCLA Health, Dr. Ashini Master is joining us. And Dr. Master, we've talked a lot about the emerging technologies in the form of diagnostics and treatments. I've been hearing a lot of buzz about blood biopsies and how cancer is specific to each person. Can you tell us a little bit more about that? And then also on the end of that, if you would just tell us sort of some personal advice that you give your patients after diagnosis.
Sure, I'd be happy to. So we typically are using liquid biopsies or blood biopsies in the context of women with stage 4 metastatic breast cancer to look at the genome and assess if there are any actionable or targetable mutations that may be driving the cancer. In these instances, we may have a clinical trial available for them, or may have a drug that we're using in a different cancer type that then we might be able to utilize for their treatment. So this is something that we are doing exceedingly more and more often as the years have gone on. It's not, I think that this field is going to continue to grow. And there is also now some evidence, it was presented earlier this year at one of our conferences, about the use of potentially liquid biopsies for cancer screening and early detection. This too is an evolving space, certainly, and I think likely has a home for cancers for which there's currently no screening. But in addition, for me, running our high risk program, unfortunately, women are undergoing a fair amount of screening throughout the course of the year because we know that they're at an elevated risk. And it can be very cumbersome and overwhelming for them while they're young women trying to live their lives, busy with their families and their careers. And this might be, I'm hopeful that it may be an option in the future to limit the amount of mammograms and MRIs that they have to undergo.
And then the personal advice that sort of you give your patients immediately after diagnosis. Yeah.
So I really try to advise them to stay present. When, of course, the first thing we hear with this diagnosis, or the first thing we feel, is anxiety, and going from appointment to appointment becomes very overwhelming. And I really try to sit with them and be present with them and have them focus on the day-to-day, take it one step at a time, one appointment at a time, and remind them that we as their care team are always available to go over things again. We don't expect them to remember everything we told them the first appointment. We want them to hear it multiple times until they truly understand what their diagnosis, their prognosis, and their treatment plan is going to look like. And I do advise them to stay off the internet. I think there's a lot of great information. We give them those resources that are trustworthy, but I want them to have their individual journey that isn't necessarily influenced by other people's process.
Yeah, it's really easy to be overwhelmed and go to that dark place when you start reading about things from people who might not have the same experience as you. All right, Doctor, thank you. Let's bring in Dr. Gregory Vidal. Again, Dr. Gregory is with West Cancer Center in Memphis, Tennessee, and we've talked about how you are serving the community of color. And I know from my work with Susan G. Komen that this often is an underserved community, and often the statistics are not good for women of color. Tell us how you encourage people to come in and have their regular checkups, and what you also offer at the clinic.
Thank you very much for that. Yes, I mentioned earlier that unfortunately, due to biology, women of color tend to have more of an aggressive tumor. We also tend to have diagnosis earlier at a younger age. And all of this does portend a worse risk. Unfortunately, patients of color, women of color, especially in my area in Memphis, tend to be of lower socioeconomy. So insurance plays a role. I have many patients. I have a clinic in the Midtown area. And I tend to see patients presenting with, although, like I said before, you have a more likely to have a more aggressive tumor, patients also present with larger tumors, larger stage tumors, because many times they don't have the insurance to get the test. Although there are, like West Cancer Center, we will test and treat any patient regardless of insurance, but many patients don't really understand that. So a lot of our work that we do within the community is really education about what's available, educating the community about really knowing your body, knowing your family history, because what happens, I cannot tell you the amount of times I have a patient come in and says, "Oh, I didn't realize you were treating my cousin. You know, my sister is here." And to me, that is mind-boggling.
Yeah, that's a red flag. Yeah.
It's really important to know your family history. If you're, and we know that, and the science backs it up. If the disease is running in your family, it's a higher likelihood of it's going to show up with you. And we know there are mutations that run in families that we test for. And knowing this family history also helps us to determine which patient we should screen earlier, which patients we should test. So that's so some of the things that we do is education, really providing mammograms to patients closer to their home, sort of mobile mammography. We participate with advocacy institution advocacy programs, organizations within the city, again, to educate. And then another thing that's really dear to my heart is clinical trials. We do see that there is a much lower participation of clinical trial for people of color. So it's about an average about 5%, whereas the population in the United States is close, at least of people consider themselves Black or African American, it's closer to 13 to 15%. So we're not participating in trials, but yet still we use all the drugs once they're approved. So a lot we don't fully understand adverse events, responses within that population. So I do a lot of education in that respect also.
All right, Doctor, thank you. I want to bring in Mark Pilon because, Mark, I know that a lot of work that Susan G. Komen is doing is also in minority communities, and that outreach is so important. How do you get the message out there?
Well, obviously it's as much marketing as that we can do, but we try to really go to where the patient is, where they work, where they live, where they play, where they pray, and involve faith-based organizations, involve everybody that we can to make certain that we do get that word out there. And we celebrate that every October by trying to create as many events as possible, doing mammography events in conjunction with other partners to be able to, like the doctor said, to bring mobile mammography to the patient when they have a challenge. I mean, here in Los Angeles, transportation is a huge issue. And for quite a while, we had a program with Lyft where we could actually get you to, during the COVID, bad COVID portion, we could get you to your doctor's appointments and to your mammography in a safe atmosphere in your own car, so you wouldn't have to take public transport and things like that. But it's, African American women die at a rate 40% higher than Caucasian or Asian women. And in cities like Memphis and in New York, in Atlanta, in Indianapolis, and San Francisco, it's even higher. Like in Los Angeles, it's almost 60% higher. And a lot of that is just due to the disparities that are in the communities because they can't get to services, or there are absolutely medical deserts where there aren't enough services available to women. Compounding that with during COVID, we had mammograms were considered an elective procedure, and a lot of places shut down and they weren't doing mammography. So now we're really concerned about the rush of later stage diagnosis, and especially with African American women and Hispanic women, that is going to bubble up in the next 2 years, 3 years.
And I think the statistics show that we're already seeing some of that.
Yes.
That people have put it off because they didn't want to be in close proximity with someone during the height of the pandemic. They put it off, and now those people are being diagnosed. So those mammograms, the annual exams, are just so important. All right, Mark, thanks. Let's go to Aubrey Kelly. Again, Aubrey is with Rabo Health, the new app that helps you build your team and track your illness. And Aubrey, I'm just really interested where the name came from. What a rabble.
Yeah, thank you. So I think most people think of rabble as the rabble rousers, which is a little bit of mob mentality. And we're not afraid of that because we're trying to actually elevate the patient voice. But a rabble is also a swarm of butterflies. And so recognizing that a cancer journey truly is transformational, there's no going back, but there's a recognition that there's 15 million survivors out there. And next year alone, 1.8 million are going to be diagnosed. And so the opportunity that we have is to really create essentially an ecosystem to help those that are a little bit farther along, let's say on a cancer path, to provide feedback, to provide input, to create those communities and give hope for future patients. And so the opportunity that we have is actually one that, and I appreciate we don't want people to go to Google, but unfortunately 98% of cancer patients are going to Google. So the idea is that can we triage content, deliver it in a way that's more specific to the individual? enable them an opportunity, should they want to actually share their data in the hopes to fuel additional research and create future hope for future patients. And so that's RAPL.
All right, let's go to Aubrey. Thank you. Let's go to Dr. Master. And Dr. Master, we talked about mammograms, how some women have been postponing them, wondering if you are seeing the implications of that. And then also, are mammograms still the baseline? We've talked about all these advancements in technology and early detection, but are mammograms still the most important part?
We are certainly seeing the fallout from COVID. We are, even at UCLA, where we have multiple imaging sites and centers, we're having a difficult time getting patients in for mammograms. The delay is quite significant. I myself already scheduled my mammogram for next year because I've been hearing from my patients that they're scheduling into March. And so it is.
Oh, so many people are trying to get in now that they can't get there. Yeah, they're getting even further
last year. Absolutely. So it's very concerning. We are seeing more women come in with more advanced disease than we would have otherwise anticipated had they received their mammography last year. Mammograms still are the standard of care. You know, the breast cancer related deaths went down by 40% when we started doing mammograms. Are they the best screening tool? It's a great question. I think there's a lot of factors to think about there. Certainly when young women predominantly, when we see they have very dense breast tissue, then we may consider the addition of an ultrasound for them. There are ongoing studies, a study that was published out of the Netherlands just about 2 years ago, looking at the use of MRIs in women with extremely dense breast tissue. This is still something that we're not ready to do in prime time. The MRIs are quite costly. They too have their own set of concerns, namely false positives. So we see a lot of women get called back for potentially unnecessary biopsies, and that's a lot of anxiety. So I think we're still working that out, but for now, absolutely, mammograms are the way to go. And I think, you know, if you can, getting a 3-dimensional mammogram is better than getting your standard 2-dimensional or digital mammogram.
So the 3D mammogram, can you explain a little bit more about how that helps with detection?
Yeah, what I can tell you is the simplest way is what my radiology colleagues told me, and they said it literally, when they see things, it just pops out at them. So it is, I think it certainly serves women, particularly those with dense breast tissue. It's increasing the sensitivity of the test, meaning they're less likely to miss something or leave something on the table.
All right. Thank you, Dr. Master. Let's go ahead and bring in Dr. Vidal again. And again, Dr. Vidal joining us from West Cancer Center. He's in Memphis, Tennessee. And just wonder, we talked about the implications of COVID and people delaying their screening appointments. What other implications are you seeing from COVID? Are people just generally afraid to come in for follow-up appointments?
I suspect that is different based on geography. So in the Northeast, the West Coast, I think people probably stayed away a little bit more than in the South. We earlier on at West, so at the heights, I would say March of 2020, for about the first 2 months, did see a dip. But right after that, patients started coming back. And there are definitely our patients so we're doing a lot more virtual visits as a result also. So we are seeing more advanced diagnoses right now. And you are correct, they're showing up now, and it's not going to be 2 years down the road. But we do see, especially the elderly patients, the patients who are concerned about their immune system, how strong it is. Those patients are tending to want to hold back a little bit. Do I really need to come in for that test? Do I really need to do that? And we have to sort of work around that schedule to try to get them in. And fortunately enough, we have virtual visit as a tool to be able to see those patients, but even that has its limitation because I cannot do a physical exam virtually. So yes, so COVID has its implications on mostly negative, not only on the patients getting COVID, but also the other patients. We know in the healthcare system, for example, in the hospitals where COVID had overrun the hospital system such that other diseases couldn't really be managed and cared for. So definitely there are lots of implications, and we will see later on even more popping up that we hadn't even been thinking about in this healthcare.
And Dr. Vidal, you mentioned virtual appointments. They're really convenient, right? It saves patients a lot of time. I know it must allow doctors to see more patients. Do patients have some reluctance that you can't correctly diagnose? And you mentioned there's some things you can't do. Certainly you can't do mammograms. And I can tell you that in my experience, I had no symptoms when I was diagnosed. So
Yeah. So virtual visits is really has been a lifesaver and has been a good tool, but it does open up some disparities. Patients who are unlikely to have really good, dependable internet really can't make use of this tool. And that tends, again, to hurt the low income minority patient, older patients who are really not that savvy technologically. Those patients are not able to use that tool. And I talked about, the limitation with the physical exam. Some patients, the whole body language, all of that sort of stuff that you get when you're sitting in with a patient, you lose that. But again, what COVID has forced is to bring technology to the upfront in what we do. So right now, there are some projects that we're working on in using sort of mobile device outside of just a virtual visit for detection, doing vital signs at home, and those are actually coming up, and more emphasis are being placed on those. So there's going to have to be a focus on trying to close those disparities that are showing up because of the digital divide. But ultimately, I think it's a good tool. We just have a lot of work to do so that we all can utilize it equally.
yeah, it's fascinating. I mean, it came about really became more popular during COVID, and now we're just progressing with that. Doctor, thank you. Mark Pilon, I know that one of the things that Susan G. Komen does is go out into the community. So to try and erase some of those disparities, can you tell me about the work? And I know they used to do mobile mammograms, and what is offered here in the Los Angeles area?
Well, now we have a thing called a treatment assistance program, where we restructured in this last year, and it was due to COVID that we restructured. But the treatment assistance program really offers help to individuals who may need help with their rent and those immediate human needs that we weren't paying as much attention to that before. And what we're doing now, like I said, is being much more patient-centric. And the other thing is we're adding a lot of navigators, because the navigation piece really helps newly diagnosed people get through the chaos and the noise and things like that. So we've added navigators on our national program, on our helpline and things like that. We're adding more this year to really help carry somebody through this horrible time of their life and make it not so horrible, and take away some of the fear and the myths and things like that, and keep them moving into a continuum of care that's going to serve them well. So we do that.
How do you make people aware, Mark, that these services are available?
Well, we're still doing things like this, opportunities like this, by doing our walks, and then we're doing a lot of educational sessions. We also have a strong advocacy team out there on the state and the federal levels throughout everything. And it's really getting out in the neighborhood, using billboards. Get your mammogram now. Whatever we need to do, whatever methodology works for us to try to get back into the community and make the community aware that this can't go away. We can't get lazy about this. This This is a very important thing. So with our helpline, with our treatment assistance program, and those kinds of things, we are now there for anybody in the United States, any woman or symptomatic man that says, I think, or I just got diagnosed. We're there for them no matter where they live. There's no space, there's no number of areas that can't be served. And so we're serving them on that level now.
All right, Mark, thank you for that. And really, thank you for all you're doing. It's time for another quick break. We're going to take a break. We're going to hear from our sponsors. We're also going to hear from some women experiencing breast cancer and who have survived and who are sharing their experiences. We've got great questions from some of you lined up. We'll get to those in just a moment. But first, this break.
Your life is precious. You matter to so many people in so many ways. But cancer never plays fair. Before a diagnosis and beyond treatment, with leading clinical research, diagnostic services, and training the next generation of cancer specialists, West Cancer Center is here to fight for your health and your future. At West Cancer Center, we care and we can.
All right, I mentioned that we have some questions from those of you who are watching at home. The first one is for Dr. Master. And Dr. Master, our viewer wants to know, this is from John, that you mentioned it's important to stay present after your diagnosis. What other mental health things should people who are newly diagnosed be doing in the weeks that follow their diagnostics?
You know, I think that to whatever extent one can maintain some routine and sense of normalcy, also exercising, talking, to maybe a small circle of trusted family members or friends who someone may know isn't going to cause them more sense of anxiety or feeling overwhelmed than they already are. And reaching out for support services. I don't think it's ever too early to reach out, whether that is at the institution that they are being treated, if available, or within the community. There, I think, of course, Susan G. Komen, and there are multiple organizations out there, local and nationally, that will sometimes pair someone up with sort of a buddy who's gone through this, have support groups. And like I said, I think it's never too early to do that.
I know one of the things that people ask me often is, should they go back to work? And I know that's a personal issue, but in the days after you're diagnosed, it seems so overwhelming just keeping track of appointments. There's so many people to see, right? So many blood work and so many tests to get done. What do you say to the patients who say, I do want to maintain a normal life and I don't know whether I should go back to work?
Yeah, I mean, I think we have to do what feels right to us. For some people, they know that they need that in their lives. That will make them feel grounded. Mm-hmm. And for other people, it will be too much. So like you said, it's something that is personal. And I try to sit with my patients and tease that out, try to talk about what are the things that are important to you? What are the things that you feel will serve you during this time? And everything else, kind of put that aside for now. And we do have to compartmentalize a bit to get through the journey. I find that from the time of diagnosis to the time of treatment, whether that's giving some preoperative chemotherapy or getting to surgery, is probably, for many women, the most difficult time. Right. There's just so much that's unknown. There's so many questions. Should I get a second opinion? Should I get a third opinion? And fortunately, in Los Angeles, we are blessed with having wonderful medical centers and options for our patients, but that too can add to the noise in people's heads. And so I try to, I encourage my patients to get a second opinion, probably not a third and a fourth, because at that point, they're probably not hearing anything that's too different, and we might just be adding to confusion and delaying their care.
I remember in the days after sending out an email at work and saying, I appreciate all your good thoughts and stuff, but please don't come up to me at work and bring this up and don't hug me, because the emotions just come and you you're right, you have to compartmentalize things. All right, Dr. Master, thank you. Dr. Vidal, your thoughts on what patients should do in the days after getting the news you have cancer?
Yeah, so again, that's difficult, and it's going to be very, very personalized. Dr. Master, was talking earlier about patients going back to work. You asked the question. For some patients, especially the mother is the financial supporter of the family, and some folks just really can't stop working.
Right.
And for those patients, it's a little bit more difficult. I try to speak to my patients about the drugs and the toxicity and the fact that the treatments, although it can make some folks tired, it can get you down, it should never be that bad that you couldn't function. And if that's the case, then we need to figure out what else is going on and try and that's for the physical body. Mentally, I think getting support is important, and the right support. It doesn't necessarily have to be a physician or a psychologist or a psychiatrist, a professional, but church, family, friends, small groups, people who've gone through that very same ordeal that you've been through, or similarly, that can give you some. I like to match up some of my patients. So the patients, especially the younger ones who have who are going through this and become very anxiety driven, especially the ones with young kids. I have a few patients that have been through it that every time I ask when they're done, I said, can I use you for the next patient? And most patients will say yes. So oftentimes I said, I have somebody who would be willing to talk to you. Would you be willing to speak to them? And then we pair them up. So again, of all of the conversations we're having here, I do want to stress that we cure most breast cancer patients than patients die. This is one of the more curable cancers that we have. And in breast cancer particularly, we have this almost down to a recipe and a science. The outcome would certainly depend on your presentation and your type of disease, but for most part, we can cure you of this disease. We just need to follow these steps in order to get you there.
I think that's a beautiful takeaway. We cure more breast cancers. Aubrey, the doctor was talking about building your team, and that's something that you do at Rabo Health. Very briefly, what's the first thing people do when they get this app? What should they do to sort of get them on their way?
Yeah, you build your team. So you first identify what diagnosis you had. So I'll give the example. In my case, I wanted a platform I could go to where I wanted it to reduce the noise and say I'm looking at an acute myeloid leukemia subtype M0 pediatric cancer. In our platform right today, you have an ability to say I was just diagnosed with breast cancer, HER2 positive, HR negative, stage 2 breast cancer. We create an environment that's specific to you, and the next step is not to bombard you with content, but it's actually to have you build your team. I think one of the things that we experienced was I got a stack of advocacy organizations about this big that could have supported us in some way or another. And I didn't actually know how to leverage that because that stack was all asking for the same information. And so what a great opportunity for us to be a resource for advocacy organizations to actually promote their services in a timely fashion based on the subtype of disease of what a person was diagnosed with, but also importantly, where they are. So women make 80% of all healthcare decisions. So as a caregiver, I also wanted to be equipped. As a loved one, I wanted to be equipped with the same information so that I could go beyond just thoughts and prayers and actually take a very actionable way of helping support my loved one. And so our hope is that that's what this platform is able to do.
All right. Again, it is called Rabo Health. Aubrey, thank you. I want to go to an audience question. And this one is going to be for Dr. Master. And Dr. Master, they're asking, what's the latest in reconstruction? When should I get my plastic surgeon involved? And should I wait to know if I'm going to survive this before we start talking about cosmetics and plastic surgery?
So we're very fortunate here at UCLA. We do a multidisciplinary breast clinic. So we actually, our patients come in and they meet the entire treatment team the first day. They'll meet their medical oncologist, their breast surgeon, their radiation oncologist. And if they are inclined towards mastectomy, or that is something that's medically indicated, and they would like to discuss reconstruction, they will meet with the plastic surgeon right off the bat. So we have them meet everyone early on. Patients seem to really appreciate that. They have all the steps of their treatment laid out for them. Certainly, there may be times where additional workup is indicated. And then we have our team identified. So moving forward throughout their treatment course, we already know, okay, this is the plastic surgeon. So as I'm, maybe giving them chemotherapy, the plastic surgeon already knows where they are in their treatment and can follow up to discuss when the reconstruction is going to occur. So I think we're very fortunate in that regard. I don't take that for granted. In terms of latest developments, I probably don't know that so well. But
so the question was, when should they get them involved? And I know that's what you do at UCLA, but if they're not being treated there, is that something that they should inquire about, say the first week?
They should. If they are doing a mastectomy, and I think we encourage our patients to absolutely seek all of the members of their care team and get them organized and get the experts' opinions. And then we can all work together to discuss, what is someone's prognosis? And do we feel that this is a good time to consider reconstruction or not? And there are times where maybe things aren't going as planned, unfortunately, with their therapy, and we may need to put it off. But I think the sooner that we get them in and get them seen, it makes it easier for the rest of us to coordinate and facilitate care and the best care.
All right, thank you. Again, that is Dr. Ashini Master from UCLA Health. We also have Dr. Gregory Vidal from West Cancer Center in Memphis joining us. We have Mark Pilon from the Susan G. Komen Foundation, and Aubrey Kelly with a new technology form called Rabble Health. So all of them joining us this afternoon. If you have any questions, please just put them in the comments section as we begin to wrap up here this afternoon. Another question. Somebody was asking, how do you deal with children? When do you tell your children that you've been diagnosed with cancer, and how do you include that relationship as you go through your treatment and recovery? So Dr. Vidal, how do you advise your patients on that? And I can imagine you're going to say it's very personal, and everybody's family is different, right?
Everybody's family is different, and it can often be very, very difficult, and it varies on the age of your kid. I think an older teenage child, I tend to advise my patients to have that conversation, because they're more likely to have a better understanding of what you're going through and also be able to help you through your process. A younger child, 5, 6, 7, 8. Those children, they really may not fully understand, but they understand something is different about mom. And so you have to find your way to let them know that, so mommy's sick and she is getting the treatment she needs to get better. So you have to really, it's personal and patient, but I do fully encourage some level of conversation, because I've had one mom, for example, who had older kids, and she's gone through this entire process without telling them. And because she, one, didn't want them to worry, all the kids in the 20s and 30s, two, didn't want them to have pity on her. And she went through chemotherapy, and I tried to encourage her. And finally, she became so ill from chemotherapy that she had to go to the hospital, and her son took her. And she finally had to open up to him. And she was like, wow, he was so helpful. and really just a little bit offended that she didn't tell him, but found the support that she needed. So a lot of patients feel like their family members can't really handle it, but you'd be surprised. I find in most situations they actually do, and they care about the outcome of the patient. And in younger kids, I think you need to let them know something is going on because they do feel the difference,
Mhm.
but you have to speak to them in sort of a different way about it.
And it's also, I imagine, what the patient is really comfortable with, because
Right.
at the end of the day, you have to focus on your health, right, and what you're
That is,
facing as well.
that is certainly correct.
Doctor, thank you. Mark Pilon, what kind of services do you offer outside of cancer treatment to families here in the Los Angeles area, and really, Susan Gentleman, across the U.S.?
Well, across the U.S., like I said, we've become much more patient-centric in this last year. It's things like being able to make sure that you have good navigation, that you have strong support system and help you build your support system. We make sure that if you need money for rent, you need money for food, you need money for utilities, that some of those stress factors can be
Right.
reduced if you call us at 1-877-GO-COVID, and we'll put you up, and I mean we'll hook you up to the things that you need to really make it so it's not as stressful for you. You shouldn't have to worry about how do I live, or as the saying goes, where I live should not determine if I live. So if you've got struggles, if you've got challenges, give us a call and let us be part of the solution for you.
Those are words of comfort. Before we say goodbye, I wonder, Dr. Master, words of comfort from you to anyone who might be newly diagnosed or is helping support someone go through this?
I think to echo what Dr. Vidal said before, that we cure the vast majority of breast cancer, and to keep that, to keep that sort of as a goal when going through the journey. It's a very traumatic experience, going through chemotherapy if required, and depending on the type of surgery, it's not easy. But as long as I think people can try to maintain a positive outlook, that can really serve them throughout their journey.
And Aubrey, once more, tell us about the technology, what we can expect in the months ahead as you start to build this, and words of comfort from you.
Yeah, sure. I think from a technology perspective, if you are going through your own journey, or you know someone who has and want to actually provide feedback, you can connect with us at connect@rabelhealth.com. We're learning, we're listening, and we're trying to essentially let technology do the hard work. And so we're really excited about that effort. In terms of words of encouragement, I think there's just a recognition that a diagnosis is a traumatic stressor for every single one who is diagnosed, and it has a ripple effect. And so we become really good at modulating blinders, as I like to say it, in the context of what's appropriate for us right now. And don't just be authentic to yourself and to your needs as you go through, but also recognize that there is an opportunity for what's called post-traumatic stress of post-traumatic growth, of actually growing after that traumatic stressor. And there are tools, there are resources, there are advocacy organizations, there are services, there are information to help us all along that path.
And Dr. Vidal, I've heard people say that breast cancer gave them a whole new outlook on life. Have you seen that in your patients?
Oh, definitely. We have patients who, people who worked all their life and now have cancer and take a different approach, more appreciative of the little things around them, the family, traveling, that sort of thing, because it does bring life into focus and let you know that, this could end at any time for some patients, for some people. But more than anything else, to me, it also brings a lot of family closer together, because you tend to have more dependence. Because again, the mom is generally, in most of the families that I see, is really the bedrock. And when the bedrock gets ill, people come, and band together around that. And so, yes, it changes a lot of lives mainly for the positive in terms of your family experience and your outlook on life. But it does, for some patients, result in post-traumatic stress. I know you misspoke on the word, but it can happen, and it can become very stressful for patients. Patients who have to take anti-estrogen therapy for long periods of time, it really changes the chemistry of your body and their experiences going forward physically. And so that can have an impact too. And we try our best, and I encourage patients to go back to their providers and see, how can you help me get through this process? And we're always there for you.
Helping us get through this process. I think that's the whole takeaway. We thank you all for your insights today. Dr. Gregory Vidal from West Cancer Center in Memphis, Tennessee. Thank you, doctor. Also, Dr. Ashini Master from UCLA. Thank you so much for your insight and your guidance today. Yeah, we appreciate you. Mark Pilon from Susan G. Komen here in Los Angeles. Thank you, Mark. And Aubrey Kelly from Rebel Health, the new emerging technology to help you deal with breast cancer and get through it. The takeaway from today: we cure more breast cancers than not. Thank you all so much for joining us for Live at 5. Thanks to our panelists. Thanks for those of you watching at home and contributing your questions. And don't forget that you can share this link on Facebook and YouTube to be watched later. Thank you very much, and have a good evening.